Hi, welcome to our presentation. It's titled Injecting Progress, Pharmacy Services Beyond Vaccines. None of the planners for this activity have relevant financial relationships to disclose with ineligible companies. Some learning objectives for this presentation are define how to develop protocols to offer non-vaccine injection services at your pharmacy practices. Summarize the current best practices required by pharmacists to safely administer non-vaccine injections. Describe common clinical assessments needed for common non-vaccine injections provided in your pharmacy practice. Summarize how to best collect and evaluate patient-specific clinical information at each non-vaccine injection visit. Some considerations before I kind of jump into the presentation here. First of all, I'm going to be talking about how to implement non-vaccine injection services at your pharmacy and how to kind of get everything started for that service. Dan is going to talk about some clinical assessments and some specific drug caveats. And then John's going to talk about clinical safety and other considerations for utilizing this service. So some things to consider when you're first starting out is where in your pharmacy will you be giving the injections? Is the room large enough for a patient and a caregiver or multiple caregivers? A lot of times, if we're considering the long-acting antipsychotics, the patients might come with a caregiver or multiple caregivers. So you have to have a room that's large enough for that, or will you have to utilize like a safe will you have to utilize creating a little makeshift area in your waiting room. Once you have your service up and running, how will you make patients and providers aware of this new service that you're offering? Are you going to send flyers out to doctors' offices nearby? Maybe there's a provider's office that you know that prescribes a lot of these medications, and it would help them out a lot if you now gave the injections for them. Do you want to send flyers to your patients? Maybe promote it in the pharmacy with some signage, or do you service group homes and you could send a flyer to the group home that you service? Next thing to consider is how are you going to schedule these injection appointments? And then with that, how are you going to keep track of when the patient is due for their next injection? So because these medications can be on different schedules every 4 weeks, every 6 weeks, 8 weeks, sometimes every 12 weeks. It's important to keep track of when the patient is next due. So at my work, we use a couple different calendars to help us to remember when the patient is next due. And then we use another calendar system to actually keep the appointment on the calendar so we know what time they're coming in. And then this is important also. So if the patient misses their appointment when they're due, then what you have to do for a missed dose consideration. At my pharmacy, we do injections 2 days per week. We don't really have like a drop-in service. Just this helps us with scheduling our staffing. So we do it 2 days per week, and then we do ask the patient or group home to actually schedule a time that they're going to come in. It just helps with our workflow and staffing throughout the day. And then lastly, the main question that's going around provider status right now, how are we going to bill for these services? So we'll touch on the billing aspect a little bit later. So implementing non-vaccine injection services, all pharmacists have to go through the appropriate training, which is available on the PSW website through this link here. Per Wisconsin law, all pharmacists must take a course that's approved by the Pharmacy Examining Board that meets the following topics: safe injection practices to prevent infections, proper injection technique and anatomy, 5 rights to administration, patient reassessment after administration, and best practices for documentation. So once your pharmacists or complete the training, then you want to set up some forms that are needed for documentation. The first one is informed consent, which is just the patient or the patient caregiver or representative giving you consent to give them the injection. And then secondly, the injection report, which will be the documentation that you're going to provide to the doctor's offices saying that you gave the injection. So for the documentation piece that's needed, Wisconsin law actually says that after administering the prescribed drug, you must notify the prescriber. So either via fax or entering it into a shared electronic record system. And then some important information to document is obviously which drug you gave, the dose of the drug, and the route, whether it was sub-Q, deltoid, gluteal, and then which site you gave it at. We're going to want to include the time and the date that the injection was given. And then similar to vaccines, we're going to want to include the manufacturer, lot number, and expiration date. The name and title and signature of the pharmacist. I always include the patient consent form and then any undesirable side effects. I also include any notes that the patient or caregiver had shared with me during our visit, which may include something like they feel that the drug is wearing off sooner than their interval, every 4 weeks or 6 weeks. If they have any undesirable weight gain, any increased agitation. So any information that I gather from the patient or caregiver during our appointment, I include on this documentation sheet and send that off to the doctor. So let's talk about billing under Wisconsin Forward Health, the provider status. So if you're billing the pharmacist as the provider, that's going to be 23, and then the place of service is 01. That's for the pharmacy. I have included some CPT codes here with the corresponding description and reimbursement. The reimbursement for CPT code 96372, the injection of drug, is only $3.31. We can go ahead and pair that with an office or E&M code listed here. Of note, the patient does have to be older than 18 years old to use these CPT codes. And then just note there is one specific one if it's a new patient, and then corresponding ones for existing patients, depending on how much time was spent with the patient. Prices provided under the Forward Health Max fee schedule are subject to change. So to get more into the billing under provider status, if you were wanting to do a buy and bill product where the pharmacist is the provider, you can reference this provider administered drug list here, and then the physician administered drug claim requirements. A lot of the long-acting antipsychotic injections are included under these provider administered drugs. So feel free to take a look at that link there. But if we're going to bill it this way, where the pharmacist is the provider, we're going to look up the corresponding J code to the medication that you're giving. And then we're going to find the amount that is linked to that J code. And then when the medication is linked to the J code, it's reimbursed per milligram. So for example, when we were looking up Vivitrol, I believe it was like $3.34, but that's per milligram. So then you have to multiply it by the dose of the medication to get what the reimbursement will be. So that's how you're going to bill for the actual product. And then after that, you have to bill either, so if they're fee for service, so then after that, you're going to bill either their HMO for the administration or office visit, or if they have fee for service, then you would bill the administration or office visit to their fee for service after you bill the drug product. Now, if you are billing it this way, you do have to attach the J code claim, the J code to the claim for either $0 or 1 cent, so that the service recognizes the J code that you're linking the office visit to. And then if we're billing this as where the pharmacy is the provider, you're going to adjudicate the claim as you normally would through your pharmacy software system. And then also, like we and then like previously you were billed the office visit and administration to either their HMO or their fee for service directly, but you still have to attach that J code to the claim for either $0 or a penny so that the service can recognize which NDC or drug you're linking that office visit to. Some other considerations for billing, WPQC is still an option if you do a CMR and a MedRec with the patient during this visit. Forward Health allows for 1 initial visit and 3 follow-up visits per year. So if you do a med reconciliation with the patient and talk about their medications, this is still an option. Just note you do still have to get the approval through DAPO. You can bill a CMR on outcomes if the patient has commercial insurance or Medicare Part D, if the opportunity is available on the outcomes portal. So unfortunately, there's not a way to pull the opportunity on the outcomes portal. It has to be already be available in the portal for you. And if a patient does have Medicare Part D and Wisconsin Medicaid, but there's not an opportunity to bill for the CMR on the outcomes portal, you can still bill under WPQC through their Wisconsin Medicaid on the Forward Health portal. Just have to add Medicare disclaimer code 8 that it's not covered under, it's a non-covered Medicare service. And we're saying that because although they do have Medicare Part D, there's not a way for us to bill it if there's not an available opportunity on the outcomes portal. So I'm going to go ahead and pass it over to Dan. Before I pass it along, I just wanted to mention that we have been collaborating with the ambulatory care team to putting together a PDF, a toolkit for non-vaccine injections that will be available on the PSW website coming soon. So keep your eyes peeled on Fast Facts for that information.
Okay, so we're going to transition over to some of the clinical assessments that we would do in your pharmacy, as most of these are going to be geared towards long-acting antipsychotics, as kind of is what we started with in the non-vaccine injection space. And then these are going to be individualized to each of your pharmacies, so you got to kind of see what fits within your practice. But the general idea is working with the medical provider and being a team with the provider, the patient, to make better outcomes for the patient. Okay, so generally for clinical assessments, what we're looking at is doing kind of what they would do kind of at a doctor visit. So getting vitals, height, weight, BMI, especially if they're on antipsychotics, monitoring for some of these side effects that some of the products might have. Also, if you're doing disease-specific injections for like rheumatoid arthritis, you might do like a hack or a rapid 3, or like if we're doing, like I said before, long-acting antipsychotics, looking at an AIMS to see if they're possibly having some tardive dyskinesia or other akinesia side effects like that. It's a great place for a pharmacist to be in, because a lot of times we're seeing the patient face to face more often than some of these providers are seeing the patient. And if they're utilizing telemedicine, which is becoming more and more popular nowadays, we're seeing the patient in physical space, and we're a great portion of the team to be able to provide some of these recommendations and make sure the patients are getting the right care and avoiding some of these side effects. A lot of these products don't work well with pregnancy, so you might want to provide a pregnancy test. Sometimes we're doing illicit drug screening, maybe for a shot like Vivitrol, where we'd want to screen for that substance force, or if we're working with an office or a medical provider that wants that screening. Generally, in my pharmacy, I just do like a stat screening, like with a urine cup, and capture that. And if the provider wants to send that off for a full panel, we kind of work with them and through collaborative practice and things like that, where we're sending that off, and the provider is generally working with the office on the billing portion of that. But now with provider status, there might be some more opportunities with that, with CPA and things like that coming down. So lots of opportunities for pharmacists here. Some long-acting drug considerations before we inject products, especially long-acting products. We want to make sure that the patient's tolerating the molecule before they get the drug. The idea here is that once the medication goes into the patient, we can't really take that out. So that medication is going to be in there for 2 weeks, a month, 3 months, and sometimes up to 6 months, depending on what product you're utilizing. So we want to make sure we establish tolerability, usually with an oral drug, and ideally for 7 to 10 days before the long-acting version is tried to make sure there's no side effects and the tolerability is there. Dose is a consideration. A lot of the manufacturers, I'm going to reference this multiple times, but making sure that we're paying attention to the package insert is going to be very important here. In the package insert and the resources, a lot of times have dose recommendations on where to start with these medications and how to titrate up and down to make sure, again, the patient's getting an optimized dose. One of the fears here is that, if you go too light, the patient might get that wearing off. The nice thing, if you kind of go on a conservative basis, we can supplement with oral. But if we go too high, you have that risk that the patient's not going to be feeling very well, or kind of, a lot of times getting that kind of drugged out, tired feeling. It's not very comfortable. And again, once it's in, we can't really take it out. So dosage is very important here. And then site, like Cassie mentioned with the documentation, is going to be really important to record and make sure that we pay attention to, because a lot of these products are very site dependent, not only whether it's intramuscular versus subcutaneous, but also what muscle we're injecting in. Generally, it's volume dependent, but also, for example, like the Invega products, for the initiation dose, they recommend a deltoid muscle, and then kind of the maintenance can go either deltoid or gluteal. So like I said before, I'm going to reference the manufacturer package insert, but pay attention to that. I even know that I've been giving shots for a long period of time. I often reference the manufacturer package insert before giving the shot, just to make sure there aren't any changes or nuances that I missed, with each injection. This is just kind of for reference and the general angles that we're looking at of doing, intramuscular versus subcutaneous. Again, it's a guide. Some of these subcutaneous shots, especially if you're looking at a patient given injection form, a lot of these subcutaneous shots are done at the 90-degree, just like the intramuscular, for ease of patient use. So again, reference the package insert. So I'll go through these pretty quick, but they're different sites that we can inject in. The manufacturer will, again, recommend what site, whether it's a gluteal or a deltoid site. Within the gluteal site, there's different sites. I generally go with most products towards the dorsogluteal site. Ventral gluteal is another option. Between the two, generally, most nursing staff that trains on these medications will tell you that the dorsogluteal and the ventrogluteal site are pretty interchangeable, even if the package inserts recommends one or the other. When I was trained, I actually trained with the medical educators, which are usually nurses that the pharmaceutical companies provide on each of their products. So I definitely recommend using them as a resource when it comes to learning new injections and in different products as they come out. A lot of the pharma companies have a lot of resources and opportunities to train and make sure that you're comfortable with giving the shot and doing it properly. So the idea with the dorsogluteal site is to inject in the quadrant, the upper left quadrant of that, to kind of get away from the nerves that go through and the IT band. Because we got to think a couple things is not only are we causing inflammation by doing the injection at the site, but then also the medication kind of going into the muscle is going to cause some inflammation. So we don't want that inflamed muscle to cause discomfort within the patient. One of the things that I always recommend using is most of these products are going to come with 2 needle sizes. Generally, I recommend using the longer needle if possible, because a lot of the pain and discomforts I've found is that the medication is not getting into the muscle and it's kind of leaking out into the subcutaneous tissue. When you get that leaking out into the subcutaneous tissue, it generally is where that forms that kind of hard nodule, and that's generally what's associated with the pain for the patient. The other common issue that I found with these injections is the person that's preparing the shot not shaking it well enough. There's actually Invega puts out trainers of shaking a product for I think it's up to a minute or to a minute to 3 minutes, and they have to shake it hard and vigorous, and it'll give you a green light or a red light if you do it properly. And I give it to my students a lot of times to kind of give them an example of how long and how hard they need to shake these products, and they a lot of times will fail on the first product. So making sure that you're shaking these products and getting them suspended properly is going to be also helpful for the patient. So this is the other side I was talking about, which is the ventral gluteal site I'm comparing it here to the dorsal gluteal. This is going to be on the side of the leg. The other reason that I don't like this site is that I feel like this one, since it's on the side of the leg, as opposed to the dorsal gluteal, which is kind of on the top back of the thigh, this requires the patient to kind of have to disrobe a little bit more, unless they're wearing shorts or something where they can maybe pull up the pant leg. But generally with the dorsogluteal site, they're just kind of having to pull down just the top of the pants. So I can easily do that in more of a waiting room type area instead of having to have a more private area where the patient, possibly needs to disrobe or take off their jeans or something like that. So again, utilizing the proper techniques and making them fit to your site is what's important. So you got to find that balance. Okay, so I'm just going to go through a couple different examples and kind of just show you some of the things that we're working with some of these products. So the first one is going to be this one, which is Abilify Mentena. You can kind of see that the product is it's a powder and a diluent in one device, and you're kind of twisting them to make the diluent go into the powder, and then you're going to shake it and reconstitute it right there. It's a This one is a long-acting form of aripiprazole. There's going to be two aripiprazole molecules we're talking about. So again, like I talked about before, making sure that they're tolerating aripiprazole before doing the shot is going to be one of the more important things with this medication. And then making sure that you're shaking and reconstituting the medicine properly is going to be important. This one is a month shot, and it comes in two different strengths, the 400 and the 300, and the dose is usually related to the pharmacokinetics and if the patient has different interactions and things like that. It's not as much related to an oral dose. You don't have as much dialing in and things like that with this one, since it only comes in the two strengths. So this is what I was talking about the, interactions and things that you might want to pick the 300 versus the 400. Generally, again, going low and slow and being conservative with the initial dosing is a good idea when switching from oral to long-acting products. So the Aristata would be a second example of another aripiprazole molecule. These come in pre-filled syringes, and the unique thing with this one is they have a couple different strengths with it, and then they also have what they've formulated as Aristata Initio. The unique thing with the Initio is that's a short-acting injection. So the patient can get a short-acting Aristata Initio, one oral tablet of aripiprazole, and the long-acting form, whatever strength that the doctor picked, and they have drug within their system basically by the next day. Whereas most of these products take time. The medication goes into the muscle, and once the muscle is saturated, the blood will then draw a product from the muscle to the bloodstream, and it generally takes about a month for that to happen. So oral supplementation with a lot of these products is very important, because a lot of times the medication is not being in the system for up to a month before the patient becomes up to steady state on these. So paying attention to oral supplementation is really important, working with that team, because not all the prescribers understand that. And then there are situations where we might want to kind of go lower on an oral dose or something like that. So again, working with the provider and being a drug expert on these products is going to be very helpful, because a lot of times you're going to know a lot more about these products than some of these newer injectors might be at the beginning. So you kind of just going to help them through it. to understand the pharmacokinetics and things like that to make sure the patient's getting the proper dose. So this is just an example of some of the differences in the products and how we would choose one versus the other. And this is a infographic of that showing that initio dose and then the different ones that it comes in like that. I just wanted to include a couple different of the traditional antipsychotics like fluphenazine and haloperidol. These are generally come in vials. The thing that I consider with these is a lot of times they come in either a multi-dose or a single dose vial, and you have to kind of make sure you're documenting on which product you're using and why. So for instance, if you're billing a multi-dose vial and then you're disposing it, you have to document that. Otherwise, the PBM or whoever's covering this might, audit you or look at that and say, you're wasting product or things like that. So, paying attention to which form you're getting this in. And then also, if you are going to use a multi-dose vial, making sure that you're storing it properly and using aseptic technique to make sure that that product is viable so you're not introducing risk to a patient or anything like that. These products, this one and the haloperidol, are kind of a thick and oily substance. So using the correct needle size is going to be important, not only the length, but the gauge of the needle so that you're not having a difficult time pushing the product into the patient. Generally, with all the products I've given, the general recommendation is push the product as fast as you can go in it. For instance, like Aristata, if you stop halfway through, the needle will clog on you and you'll have to kind of take out the needle, switch the needle out, and inject the rest of the medication in a nearby spot. So keeping that steady, generally fast injection technique is going to help the patient not have to get poked more than once. Needle clogs are pretty rare with most of these products. Most of them are pretty easy to administer, I would say, with the one exception being Vivitrol, which we'll talk about in a couple minutes here. In Vega, I wanted to include this one. This is what I was talking about this one having some deltoid or gluteal spots. So this is the one that the initiation dose has to be done in the deltoid, and then the maintenance doses can be picked between different sites. And Vega comes in a variety of different strengths, and they have dosing options monthly, 3 months, and then a new 6-month shot. So you have some different tools that you can use for different patients. I would argue that if you have a very inadherent patient, to not just try to gravitate to a 3-month or a 6-month shot right off the bat. The manufacturer and generally best practice is to get the patient steady on a monthly dose before you start going to a 3-month or 6-month option. Because like I said before, you can't, if you inject somebody with a 6-month shot and that's not the correct dose for them, then you have to worry about oral supplementation, or if you went too high, you don't have a lot of options there. So making sure that, again, you're picking the right product for the right patient on this. This one also has a loading dose. So the first dose, we give a 234, and then we do 156 on day 8, so 7 days later. So it also introduces some complexity if a patient is inadherent and doesn't come come when they're scheduled for. Like Cassie was saying, pharmacies need to utilize a scheduling system, and ideally one that when the patient is due and when they're missing doses to notify the doctor. But also for situations like this is, do you have to reload a patient? A lot of times in psych and in these areas, we get kind of these gray areas. If a patient has to be reloaded at 6 weeks and they come to your pharmacy 6 weeks in a day, are you going to reload this patient? Are you going to just give them the maintenance shot again? Are you able to contact a doctor? Do you have a working relationship with that doctor that they know, if my patient comes after 6 weeks, I'm just going to reload them, and I have some sort of, prescriptive or CPA that says that I can do that, or do I have to contact a doctor and get a new script? And then you introduce, is your patient going to wait for that phone call? Is your patient going to wait for you to process that new prescription? So lots of different things, so which makes that relationship between the doctor, the provider, and the patient extremely important to work out and try to come up with solutions to these different scenarios before they occur, because scenarios and difficult and gray areas will come up. So, utilizing your clinical judgment is going to be important there. And it's the more you know about these products, the better spot you're going to be in for that. So this is what I was talking about as far as the missed dose recommendation. So I wanted to include that in these slides just for reference here. This is an example of kind of some of the dosing cards and the package inserts, which would be included in all of the packages. So these are the things that I referenced before doing the shots, not necessarily looking through the whole entire, medication guide. I'm usually looking at these examples like this of telling me what I'm doing, what strength I'm doing, and where I'm doing the injection. All right. This is a kind of a newer form of injection. This is an example of a subcutaneous shot. It's actually the same type of formulation as this Sublocade shot. So this one has a little bit different prep to it, and then you're also doing a sub-Q injection at that 45-degree angle. And you're dosing this monthly or every 2 months, and basically you're dosing this into the subcutaneous tissue. So you'll oftentimes see a little dot, kind of similar to what like a TB test looks like. And sometimes that nodule, sometimes it gets a little bit hard, sometimes it doesn't, depending on the patient. It's okay if they do see the bump. It's okay if they don't see the bump. But you generally just, the thing with this one is just have the patient, kind of not rub the area and irritate the area and things like that. But other than that, kind of a unique product here. And then stay tuned because I'm hearing more and more about pharmacists being able to administer the Sublocade shot. So having another option for some of these alcohol and other dependent substance patients down the road is going to be really helpful for that. So Vivitrol, talking about AODA, as a product for both alcohol and opioid abuse. It's a great product for that. The biggest issue with this product is that it's a complete blocker, so we need to make sure that the patient is not actively using any opiates at the time. And if they're drinking actively, it can also be an issue. So we got to make sure that the patient's abstinent before receiving this medication. Generally, my pharmacies that I do these shots in, I'm getting them CLIA waived and doing a stat urine test on site when I do this injection. Even if a patient is coming right from a doctor where they were administered a drug screen and came back negative, I'm still doing it at the pharmacy just to make sure that nothing happened between them driving from one location to the other, as just a precaution for me. Again, utilize your best judgment and what your practice authorized, but it's worked out well for us to do that. This one is kind of a milky, thick substance. It's a traditional 2-vial system where you're pulling up a diluent and injecting it into the powder, shaking it. This one, out of all the products I found, that might be one of the harder ones to administer just because of the thickness of it. And a lot of times if the patient kind of tenses their muscle or anything while you're injecting, it can cause some clogs and things like that. So this one, I think of all of them, requires some practice before you're going to do the injection on this one. But I think it's a very important medication for us to be able to be involved with because it gives patients a good option for being, drug-free or alcohol-free. This one's not as common, but another example of, hey, your pharmacy might want to do some B12 shots as another area to either work with a doctor in the area that's, doing B12, or if you're doing this as kind of a cash service or something like this, it's a pretty easy injection to give. It can be done IM or sub-Q. And it's a aqueous solution that's, like I said, very easy to inject. So another option that we can use kind of for your pharmacy and in other instances and things like that. I think that's all I had. If any questions pop up, our contact information is in the slides. Feel free to reach out to me. I can answer any questions that you have. Thank you.
Hi, I'm John Lemke, pharmacist at Stru's Pharmacy up in Green Bay. We have been doing a long-acting antipsychotic and Vivitrol injection program since 2016, and I'm here today to tell you a little bit more about some of the nuances that I've learned and wish I knew when we started our program 9 years ago. We can move to the next slide. First, kind of a busy slide here, the type of information that you should have prior to onboarding a new patient, both for best clinical practice and to protect yourself. The first one I have here is the authorization to inject. There are two different ways that you could go about doing this. One would be by standing order or by individual prescription. I really prefer the latter because things can change that you may not be privy to. However, when you do have a standing order, you might be able to include verbiage that allows for you to alter the date of injection by 1 or 2, depending on vacations, missed appointments, stuff like that. Regarding the date due and the date of the last injection when you get a new patient, it's pretty critical for discharging patients in particular. I do require that information from provider, confirmation of when it was from provider. I don't like going by patient's word. The date of the last one is important if there's any thing that involves titration or reinitiation that's necessary prior to that due date for their next injection. More information, the better on that. So I don't necessarily always go by when just the next due date is printed on the prescription. The provider, him or herself, may not have all the information in that case either. Regarding full med list, of course, this is all your regular onboarding stuff, problem list, allergies. The CMP and pregnancy test are less crucial. I like to just have it on hand. Generally, the patients who are receiving these aren't folks where I'm worried about serum creatinine and stuff. I'll look at the liver panel. Pregnancy test, more of something where you can ask the patient, sign off on and agree that these are the things that could be at risk in receiving any particular injection, but they're also things that you would educate on part of your consultations. So not necessary. When it comes to Vivitrol, I had done that, but again, what's worse for a child, the opioid use or getting naltrexone? If you have a patient who's coming to you from a facility and they're discharging, the face sheet would have pretty much all of that above information. The other thing I would ask for from the provider at the hospital that would be discharging to you, patient that would be then coming to you, would be the admission summary. That would be effectively their onboarding paperwork of patient. You'd know why they were admitted, how they presented, and what their med list was, which might be very different than what you have if you have one at all. So you know what changes were made as well in the hospital. And finally, when they do get released, the best thing to ask for would be that plan of care. A discharge summary does not have to be written right away. In fact, it could take up to 30 days for that to be finalized. But when a patient leaves, there will be a plan of care. Think of it like an after visit summary. A couple other things to consider, or at least ask about, is the power of attorney, if there is one. If you have a patient who may not be in charge of making their own healthcare decisions, or it's a minor, very crucial to make sure you know that information. That will come into play when it comes to signing the agreement to receive medical care. And EM1 status, we'll talk a lot more about that, but that involves patients who pose a special risk to themselves or to others. And we can move on to our next slide. This slide I have to apologize for. I'm missing another point there at the bottom, but we'll get to that as we go along. Regarding the TD Ames or abnormal involuntary movement scale, you don't have to do one of these, but it is something where I would be looking out for it and may perform one if I deem it appropriate. This is something where I would put my observations in my clinical notes that would end up going to the provider. And if I do notice something like that, I may ask the patient to do something like count backwards from 20 by 2s, or name 7 farm animals. And the reason I would do that is, of course, with tardive dyskinesia in public, folks are pretty good at masking those. And if you're doing a consult in the regular pharmacy, I would recommend not doing that. Do that in the room where you'll be given the injection. Folks are pretty cognizant of masking those. So if you give them another task, such as the counting backwards or reciting the alphabet backwards, that will hopefully allow them to take their minds off that. And you might notice some stuff that they've otherwise been hiding on you. Stuff, just looking for those movements, of course, in the face, trunk, extremities, well, any of those non-rhythmic movements. You should train yourself for recognizing, and anybody that's working there, in fact, for the difference between dystonia, pseudo-Parkinsonism, and true tardive dyskinesia. And you should know when to recommend change. Being able to do this will help you provide better care and, of course, inform the provider and be the advocate for your patient when medication changes are needed. If you find a patient's on benztropine, for example, there is, however, if you Google TD Ames, forms. You'll find plenty of those online. AACAP has one of those that are useful, or if you go to Ostito's healthcare provider's website, you should be able to find where they have the tear sheets that show a quick once through assessment. Also, there's plenty of videos online as well. So Psychiatry Times, in fact, I know has one, but again, you can Google, find quite a few of them out there. Weight monitoring, of course, with the antipsychotics, you do have that, all those metabolic changes, and the monitoring is useful for both yourself and doctor. And of course, a lot of patients may request that. One of the things that stops them from wanting to receive the treatment is weight gain, among other side effects. You can also do a blood pressure. Remember, there might be billable services. In fact, patient education could possibly be as well. The questions that I do ask at consult, I can send anybody our version of forms for the different injections should you like to see them, or the blanket list of questions that we would ask at consultation. The things would include: what medication changes have you had since the last time we saw you? How is the injection site? Have you noticed any longer lasting symptoms of soreness or a lump present, something like that? What side effects are you experiencing? I'll rattle off a list of a lot of the ones. Is this medication lasting the duration you expected it to? Have you been having thoughts of self-harm? I'll ask about impulsivity changes each time, especially with the partial dopamine agonist, aripiprazole. Really, anytime you have a patient that has a history of mania, I find it important to follow up on that. You may find that beneficial, and also that could be a warning sign, which I'll get into a little bit later when we talk about EM1 status. Let's see, we can go on to the next slide again. Speaking of EM1 status, we can talk about that right now. In fact, the EM1 status is when a patient is posing a special risk to themselves and others. I'll go through a little bit more detail on the next slide here. It's going to be helpful for you to know what you're getting into here, and whether you may not even want to take a patient on at all. Let's go on to that next slide, in fact, because then we can talk about all this other stuff. So when it comes to EM1 status, a little bit background here. Anyone can initiate the process for EM1 status if you believe that a person is a danger to themselves or others. This might be a family member, this might be a provider, it could be you. And at any stage of the game, you can do this. At the point that this starts, what happens then is a person would end up going to a gatekeeper, which is usually a crisis center, or it'll be the psychiatric hospital themselves. And upon presentation, then the clinician there would have 3 days to decide what course of action to follow. Would they be dismissing the patient? Would they be doing a holdover? Or would the patient be committed? I'll go through those a little bit more detail, as that will impact you as the one giving the injections. And oftentimes you're not privy to all this information. It's helpful to know what you're getting into. The first case would be after they're in the hospital. They are discharged on their own recognizance by signing basically the clinician decides that the case is over here. The fire's put out, and you're okay to be out on your own recognizance. The second case would be similar to being released on probation. In this case, we call that a 90-day hold open, and that involves some legal stuff. A patient will have a lawyer, and between the doctor, the lawyer, and the patient, they will negotiate an agreement that involves they have to go to the appointments, they have to not take any drugs, abstain from alcohol, not pose any threats to others, take your medications, that sort of stuff. But then otherwise, they have their own personal freedoms. They just need to behave for the 90 days. Caseworker will be assigned in this case. However, they'll have minimal involvement. The key thing with the caseworker is the onus isn't on you to share information with the caseworker. They would need to be the ones to request it. And usually what they'd be requesting is just let them know if a patient no-shows for an appointment. And again, it's good to know who they are, because you may have questions for them, but we'll get into a little more of that a little bit later too. And the other thing that's nice about the caseworker is it gives you someone to call if you are seeking out more information regarding patient, or the family members themselves might have someone they can talk to as well. The third case would be an actual court case here. A lot more legal stuff involved. Most of it that's applicable to you would be after they are released. This would be something that's kind of like being released on parole with probation. However, in this case, you haven't been able to negotiate your own agreement. You're going to do what you're told here. So in this case, you might have a patient that is not there on their own volition, and don't expect the court to tell you a whole lot. I did have a patient one time who was assigned to receive their medication from us. No one told us anything. They showed up one day wanting to get it with a caseworker from the county. I did not realize there's court information, but that's the kind of stuff that's not it's nice to know what you're getting into, because you may or may not want to accept that patient. They might be referred back to receive it at their provider's office. You may not want to take someone on. Let's see here. Outside of that, the main thing with the EM1 status is you know what you're getting into when a patient comes to you. Let's go on to our next slide here. I'm just going to throw this one out there too in case you hear this term. Corp counsel, that's basically not the case manager. It would be somebody from the county that would be handling all the legal stuff. So they're the ones that's going to coordinate everything with court. In a crisis, it's mainly where the police are going to go. Corp counsel is ones that relates any kind of proceedings that's going to take place. And again, this is more of an issue when you have the patients who are involuntary. In this case, you may want to require things for extra protection, such as accompaniment to the appointment for patient, so you're not in a room with just the patient. Let's go on to our next slide here. Regarding the documentation, again, the only people I will share this information with is the patient, myself, and the healthcare provider. That is it. A patient may be there receiving the injection not on their own volition, but they do still have the right to privacy. They may not be in charge of making their own healthcare decisions, but again, they do still have that right to privacy. So I would only do this upon a patient's request to share it with others. Sometimes I'll have a patient ask that, hey, just I want to make sure that they know I'm following up on my end of the bargain. So please also let my whatever it is, the parole officer know that I got this. And again, in that case, I only tell them that they did receive the injection and when. I don't share my clinical notes with them. Moving on to our next slide. One thing I want to put in a little earlier than we get to everything else here is the missed and cancellation appointment policy. This is one of the things that has burned us more than anything throughout our time at Stru's, giving the long-acting antipsychotic and Vivitrol injections. We now have a policy where you sign the agreement upon admission. It's one of the onboarding pieces of paperwork. In our case, we do have a two-time, no call, no show policy. That means you can be discharged from our care at any time. I do let patients know you always can call in advance. You can call in advance. This one isn't going to count. So give us the day before, no problem. We can reschedule. And we understand, emergencies might come up where you have to cancel day of, but the no calls and no shows, we can't do that, especially when you're dealing with refrigerated injections. I got some special policies for that as well. If you are receiving Vivitrol or Uzedy, Risperdal Consta, if you've made my naughty no call, no show list, I will require you to wait the entire warm-up time for the injection after you sign for the product. At that point, you have taken possession of the prescription, but it has to be administered by a healthcare professional. I will not hand that over to the patient. And if you decide you don't want to wait and leave on your own volition, you left your product at the pharmacy. I'm not going to give it to anybody else, but maybe another healthcare professional to be administered. And if it expires in that time, that's not on me, and we're not going to lose the money for that. We've had it happen before where we've taken a refrigerated injection out, patient no-showed a third time. Now the clock's ticking on the product. I got to find another patient who will take that within the period before it expires. And at $1,400 an injection, we're not going to be doing that. Other considerations, let's see, you don't have to discharge a patient. That's going to be a clinical decision on your end. There might be reasons that you have no call, no shows. Was there no minutes left on their phone? A lot of times you have patients who have very limited resources. Were they in jail? Were they in rehab? Were there other circumstances where they were not of sound mind? Use your professional judgment on whether or not you are going to keep a patient, but this does give you some recourse and documentation to say, hey, look, this person no-showed, sorry, doc. They're going to have to find a new place to be treated. Let's move on to our next slide here. One thing I did want to mention is that you should always think of other opportunities when you get a new patient here, whether it's something as simple as transferring meds in, so you got a new patient, provided you're getting reimbursed for them. Thank you very much, private, vertically integrated healthcare. But if you offer other services, there may be opportunities in addition to what I have listed here. These are just some things that we offer at Stru's. Also, I mentioned earlier, when you do notice that, oh, wait, we might have someone with TD here, you need to go in for a full assessment, and then we need to recommend the doctor that maybe we stop the anticholinergic here. We should take a look at using the Austedo or Ingrezza, and opportunity to perhaps, depending on the insurance policy, you generate more income. Of course, the way things have been going of late, you may not want to do that, but in patient's best interest, that may be the course of action that you're going to recommend. Let's move on to our next slide here. Regarding the forms I have patients agree to up front, one is that you understand our no-show, no-call policy here and how the appointment policy works. A lot of folks treat it like coming in to pick up a prescription. You have to, again, think about it. This is an appointment just like at a doctor's office. I reinforce that with patients and try to avoid right up front that whole missed appointment, late appointment thing. Understanding mutual responsibility, this is where I like to reinforce to the patient that we're going to hold each other accountable. We're not here merely to give you the shot. This isn't like a drive-through where we're just providing a product for payment. We're going to be part of the healthcare team here. We're going to be on your side and advocate for you more than just your psychiatrist. You're going to see us more frequently, in fact, than your doctor, most likely. We'll be here every 28 days. We can be your eyes and ears. We can be the conduit to get more communication to your provider for you, but you got to hold up your end of the deal, make your appointments, make your commitments. I do like to make sure that folks who receive Vivitrol do understand the risks of trying to overcome the blockade. The opioid receptors here, should they, fall off the wagon and go back to taking their old doses, or, just take more and more so they can reach that high. Same would be true for alcohol. If you feel like you need more alcohol to catch that buzz, you understand the risk that this can lead to death. And I do have folks initial on that at every time. It used to be that we would do the urine testing. However, we decided that we're not going to do that going forward. We weren't able to do comprehensive testing with our kits anyway. Fentanyl wasn't tested for, buprenorphine. So even though we had a patient sign off on the original agreement that they understood that if they were not clean of opioids for 7 days or for 48 hours without alcohol, they do encumber this risk. They understand that lying to us is going to be on them. And we've done our due diligence, but in better protection of us and better patient care. Each time I do ask them at the appointment, has it been more than 7 days since you have last used any opioid? Has it been more than 48 hours since your last drink? Because you can't always take people at their word. I do like to have that initial or sign off on each injection. I did have a time where a patient came in, told me their last drink was 5, 6, 7 days ago, whatever. However, doctor didn't sign the order to inject. So I went to our Epic. We luckily have Epic access to that healthcare provider's office. Found out that the day before he was in the emergency room, alcohol poisoning. He lied to me. So that's part of the other agreement is a patient lies to you. I may discharge you right there. If I think you're posing a risk to me or yourself, and especially, in cases where others are involved, I do not want to treat you as a patient. I think you violated the trust, and I'm not going to encumber that risk. Backwards from the point of harm, I'll be the first one with an insurance policy, and I don't like going to court. Let's see here. Other thing is the mental health disclosure document. If you do have access to electronic healthcare records, mental health are not necessarily part of that. You will need special permissions to access that information. However, you can also request that from the provider who has decided by order of injection that you're going to be now part of that team. Moving on to our next slide here. All the stuff I talked about with the EM1 status and the different types of patients you may be taking on are more to be advising you as to the kind of risks that you're taking on, extra precautions you might want to take. At my pharmacy, we actually have a fairly large staff here. We do have a team of nurses as well. So we have it set up where there is one person in the room who will be doing the documentation, written form, and another person will be performing the injection. If it's a female patient, I do require that there is an additional female in the room with them. Having that witness might come in handy when it's your word to get someone else's. One time we did have a patient attempt to sue us for improperly administering the injection. I only had one person given the injection there at the time. It was frivolous, it was dismissed, but nonetheless, you don't need to go through that hassle. Should any situation present itself, you want to make sure that you have a direct line to emergency services that are going to come real quickly here. Same thing for having some kind of code you can page the overhead speaker, so folks know that there is an imminent threat. Follow your emergency procedures, whether it's to evacuate the building, call 911, whatever may be warranted in your plan there. Let's see, risk assessment for staff. Once you inject the drug, of course, you can't get it out. So we do more than just 2 patient identifiers. We will call all this out step by step. And even though it gets a little annoying for a patient when they're getting their 25th injection, confirming their name and date of birth. Same thing would happen for any surgery you go to or stuff like that. So we do verify from our previous documentation in the chart where the last administration site was. Of course, our 5 rights of, you got the right patient, right drug, right dose, right route, right time to administer. And we also will do this. We will provide documentation for anything that's outside the normal prescribing parameters for a drug, whether that be dose or frequency, that we did our due diligence to question the prescriber, say, is this actually what you want to do? Is this clinically warranted? Move on to our next slide now regarding late administration. I do recommend that in your injection room you have paper printed copies of these, or at least some resource very readily accessible. So when you do have that patient that came in, let you know, is this somewhere we need to do anything additional? Are we doing oral supplementation? Are we going to need to retitrate? Oftentimes it's a matter of, we'll still give you the injection because you give it as soon as possible for, whatever. Say it's Abilify, then you can reach out to provider, be like, hey, as long as we're doing this, should we do the 7 or 21 day supplementation of, oral aripiprazole, or are we going to use Arisata Initio to retitrate patients, stuff like that. Let's see, I also had physician's order. Again, that's something where I would just for insurance audit purposes, send me the order. Don't just tell me over the phone, yeah, you can go ahead and do that. Less of an issue for a few tablets. However, if you're going to go with the Arisata Initio, I don't want to lose that money because some insurance company, don't get me started on that. Moving on to the next slide here, a little bit more about the discharge policy. Mentioned this a little earlier, but the patient that may lie to you in a way that puts you, your staff, or even patient at a position of liability, higher risk. That would be a good reason to do it if the patient breaks the agreement for what they were going to do or the appointment policy. And importantly is to consider for violent behavior. I do have this written right into our patient agreement form. And again, if anybody wants a version that we have, a copy of what we have at Struze, I'd be happy to share that with you. Just reach out to me. Violent behavior, we do have had a patient, I should say, who, by virtue of us getting the clinical notes, we knew had a history of violence towards women. So we set up that there's no way that one of our female injectors was going to be providing this injection. Only males would be involved in the patient's care. Later, we determined this patient was too much of a risk for us to handle. Physically, we would not have, even with 2 people in the room, been able to handle this guy if he had snap, for lack of a better word here. Moving on to our next slide then. Here's something that's fairly important, is that the providers really understand your process and that you really understand theirs. When I first started doing this, a provider would say, this person needs their injection. I understand you're doing it. Can you give it to them like now? Well, we're just starting this up. So of course we wanted to accommodate the providers, realize that got us into a lot of trouble. So now, just like any other clinician's office, folks are going to have to understand that appointments need to be set up in advance. We have turnaround time. We need to get things billed for the patient. We need to have a lot more information. So we won't do anything for at least 24 hours, except in really extreme cases now. A good thing that you might want to do is meet with the providers in your area, particularly at the inpatient settings, and let them know not only that you're offering the service, but list the kind of things that you need. I do have a list of other things, I should say, of the things that we need that were in an earlier slide here. If you want to get a copy of the communique that I've prepared for providers, I can also share that with you. Just reach out to me again. Yeah, and if you do this kind of stuff in advance with the provider's office, Hopefully it won't be a matter of fixing, getting information that's incorrect, but having everybody be on the same page when you first get started. Okay, and that pretty much wraps up my portion of this. I thank you for your time, and should you have any questions or you wish to reach out to me to get any copies of what I have to I'd be happy to share it with you. You can reach out to me at Stru's Pharmacy. My email is jlemke, that's JLEMKE at struspharmacy.net. And I'd be happy again to answer any questions that you have. Thank you again for your attention. And here comes the CE code for the credit. Thank you.